Your doctor may recommend an arthroscopic rotator cuff repair if your rotator cuff is damaged. The rotator cuff is made up of 4 muscles and tendons that anchor the head of the upper arm bone, the humerus, securely into the socket of the shoulder joint. The muscles of the rotator cuff pull on bands of tough, inelastic tissue, called tendons, to raise and rotate your arm while keeping the shoulder joint stable. A torn rotator cuff causes arm movement to be painful, limited, or impossible, depending on the severity of the tear. In the most severe injuries, the tendon is torn away from its attachment on the head of the humerus. Because blood supply to tendons is poor, a rotator cuff tendon is unable to heal itself after a complete tear, and you will need surgery. Your rotator cuff can be injured by falling, lifting, pulling, or doing repetitive overhead arm motions such as pitching, swimming, and painting. In addition, the normal wear and tear that accompanies aging can weaken and break down the tendons. Your surgeon will begin by making 2 small cuts in your skin to access the inside of the shoulder. Next, your surgeon will insert an arthroscope. This device contains a light, a camera, and tiny surgical tools. The arthroscope will project images onto a TV monitor to guide your surgeon's work. Your surgeon will make a few more small cuts using small tools to examine your shoulder joint for unhealthy tissue and repair the torn tendon. Next, your surgeon will drill a few small holes in your bone, wherein implants, called suture anchors, will be placed. Your surgeon will loop sutures through the anchors and stitch them to the repaired tendon to reconnect the tendon to the bone. The anchors and sutures will gradually be absorbed into the healing tissues. At the end of the procedure, your surgeon will take out the arthroscopic tools and close your incisions with stitches. After the procedure, your shoulder will be placed in a sling for support and protection. You'll spend a few hours in the recovery room and will most likely go home the same day.
All right, we're inside your shoulder joint. This is the ball and socket joint. There's the socket. This is your biceps tendon right there, which has a little partial tear. You can see that the tendon's damaged right there. So now, this tendon, this is an auxiliary tendon for the biceps muscle. This is not the main tendon. When we see this kind of damage, the problem is we can't sew this back together. There's no blood supply to this here. So what we do is we release the tendon. It retracts a little bit, then heals in place. So that's the right treatment for that problem. It won't affect your function, believe it or not. So we've done this many times with other patients in the past, and it works very well. So the reason we can get away with this is the so-called short head of the biceps, which is the main attachment, is still intact outside the shoulder, so that'll heal right there in that position. Now let's look at the rotator cuff tendon. So this is the underside of the tendon. I mean, that looks to be attached on the underside, so I don't see a hole, at least not that I can detect, but it doesn't look normal either. It's kind of collapsed down on itself a little bit, so we'll look on the other side to see what's going on. There you can see a little, very small cartilage defect there. That's old. It's not causing any problems. So this is where your previous surgeon did a prior decompression right here where they removed some bone. There's probably still some left over here that we may need to deal with. But for the most part, you can see just a little bit of fraying here where this has been impinging on the tendon. You can see how this has become delaminated here. So that's probably why we saw that abnormality on the undersurface of the tendon. So this is easily repaired. We'll fix that back to that point. All right, so you'll see you have this residual spurring from about here all the way across to here. So we're going to remove that because that's likely still causing some impingement issues. Start over here. They removed some bone laterally, they just didn't quite finish it in the front. Big stalactite here. All right, so you can see now, kind of flattened out that spur. That looks a lot better. Okay, so a lot more headroom now for the tendon, so it won't get squashed anymore. All right. All right, so this is an anchor that I'm putting into the bone where the tendon tore away. We're going to bury that in the bone. This has suture attached to it. You'll see the anchor's buried way down in the bone there. And now we're going to grab a couple of these sutures. We're going to pass them through the torn tendon. And this nifty little suture passing device that we use. Up here a little bit, and then we'll grab the tendon. We'll pop the suture through there like that. Stuart will grab it, we'll pull it through, and that's how we go about anchoring this back down. We'll just keep passing sutures until they're all passed through the tendon. Then we'll secure them again with a couple more anchors. So there's the finished repair. You can see we brought the tendon back down. There's our other 2 anchors. That's looking really nice and solid there, so it should work out well.
The suture bridge is a technique designed to repair injuries to the rotator cuff, the group of tendons that stabilize the ball in the shoulder socket. If a torn rotator cuff is not repaired, arthritis may develop in the shoulder. The surgeon begins by identifying the tear in the rotator cuff tendon. The cuff is brought over to its original attachment site to ensure that the repair can be completed without tension. Once the bone and soft tissues are prepared to reattach the cuff, the surgeon creates a bone socket. A corkscrew FT anchor containing sutures is placed in this socket. and the sutures are then passed individually through the rotator cuff from bottom to top. The suture is retrieved and stored in a cannula. The process is then repeated with a second anchor. Sutures in the second anchor are a different color to allow the surgeon to easily distinguish them from the first anchor. For average-sized tears, 2 medial anchors are used. The surgeon then creates 2 additional sockets laterally. Sutures passed previously are crossed and secured to the bone using knotless push-lock anchors. The double-row rotator cuff repair is complete when both sutures are securely fixed to the bone in all 4 sockets.